My name is Karin van Galen. I'm an adult hematologist working at the Van Creveld Clinic in the UMC Utrecht in the Netherlands. And I'm giving you this e-learning module on behalf of the EAHAD Women and Girls with Bleeding Disorders Working Group. This e-learning consists of 3 parts. First, state of the art on heavy menstrual bleeding and bleeding disorders. Then case discussions, real clinical cases, and we end this e-learning with the latest review of the literature. So we start with state of the art. Many women with heavy menstrual bleeding may have an underlying bleeding disorder. Unfortunately, there's still frequently a diagnostic delay from first bleeding symptoms until a diagnosis of a bleeding disorder. The median time from first symptoms to a bleeding disorder in women is somewhere between the 8 and 16 years even. Also in hemophilia treatment centers, healthcare providers fail to identify female members of known affected families. So missing, again, women with bleeding disorders. What we need is the use of standardized bleeding assessment tools, or at least to take a bleeding history, to determine a bleeding phenotype and involve expert hematology if indicated. There too, we need increased awareness of healthcare providers, both the first, second line and diagnostic pathways to enhance our working together. And also we need within the hemophilia treatment centers systematic testing systems and appropriate registration of potentially affected family members of people with bleeding disorders. Heavy menstrual bleeding is a very common symptom in women with bleeding disorders and is self-reported by over 80%. Despite this, there's still underdiagnosis and undertreatment of heavy menstrual bleeding within hemophilia treatment centers. This has a major impact on quality of life and social participation of women with bleeding disorders. This was illustrated by an EAHAD survey that the Women and Bleeding Working Group has performed in 2019, where it appeared that 42% of the hemophilia treatment centers by that time still lacked heavy menstrual bleeding management strategies, and most HTCs even did not offer combined gynecology hematology clinics to their patients. When we have a woman with an inherited bleeding disorder and heavy menstrual bleeding, it might not only be her bleeding disorder causing this pathology. It could also be a structural gynecolic cause that gives her the heavy menstrual bleeding. So we should work in multidisciplinary teams and also exclude all normal pathology that can cause heavy menstrual bleeds. How can we recognize heavy menstrual bleeding in women and girls with bleeding disorders? We can educate them on the 7-to-1 rule, which means their menstruation takes longer than 7 days. They need to change their pads every 2 hours or more often and have blood clots. And they lose blood clots larger than €1 coin. Here it's also a problem that they normalize excess bleeding because other family members have the same. And some healthcare providers may also be familiar with heavy menstrual bleeding and don't see it as abnormal. So we should educate both healthcare providers and patients, as well as family members of women and girls with bleeding disorders. Ideally, written information is provided online or on paper. Here too, we are currently working on a menstruation leaflet that will appear soon on the website of the Women and Girls with Bleeding Disorder Working Group of EAHAD. What's not helping here also is that self-reporting of heavy menstrual blood loss is less reliable. So we strongly encourage healthcare providers to ask their patients to use the Pictorial Bleeding Assessment Chart, or PBAC, which is available in several apps, to score menstrual blood loss every month, and the excess bleeding correlates with a PBAC score over 100. Also, iron levels should be checked regularly because low ferritin does always mean there is an iron deficiency, and this can cause problems, for example, concentration problems at school, even if it doesn't even has caused anemia yet. So, close collaboration is needed between the Hemophilia Treatment Center and gynecologists. If possible, joint clinics are very good tool to improve patient care. This has multiple sides. Both undiagnosed women with heavy menstrual bleeding may have an underlying bleeding disorder, and we should prevent delay to diagnose a bleeding disorder because it may have treatment consequences. If a bleeding disorder is already present, we should not be delayed with the diagnosis of heavy menstrual bleeding and start management soon to prevent social impairment. Also here we have to work together and make diagnostic and treatment pathways to make clear how to do this. Here's an example of a diagnostic pathway. So first, to diagnose a bleeding disorder in a woman with heavy menstrual bleeding. If this is unexplained, there should always a bleeding history be taken by first or second line healthcare providers who see these women. And if this is suggestive for a bleeding disorder, ideally a structured bleeding assessment or bleeding assessment tool should be used. And then laboratory assessment. At first, blood counts, platelet counts, and screening of secondary hemostasis with APTT and PT, and von Willebrand activity could be measured because von Willebrand disease is the bleeding disorder that occurs most often and causes heavy menstrual bleeding in many women. And of course, check iron levels. If there's a persistent suspicion for a bleeding disorder after these assessments and after doing these ICH bed tests, then the patient should be referred to a hematologist. Another diagnostic pathway is needed to adequately treat and refer women with bleeding disorders who have heavy menstrual bleeding. They should have received education at the HTC before they even start their menstruation. And when they have symptoms that are suggestive for heavy menstrual bleeding, they need education how to manage it, diagnostics such as the PBAC score and blood levels, including iron levels, and start first-line therapy. If this is not sufficient, then we can refer to a gynecologist or see the patient together with a gynecologist to make sure we do anything to prevent problems due to their heavy menstrual bleeding. So how to manage heavy menstrual bleeding in bleeding disorders? Chronic heavy menstrual bleeding needs multidisciplinary care. First, to diagnose it, 7-to-1 rule. Iron deficiency with ferritin levels below 30 are suggestive of too much blood loss. If they need to change their pads at night or need incontinental materials, if they flood, so like there's a tap opening when they lose blood, if they lose social participation during the menstruation, and with a high PBAC score, as mentioned earlier. Then what to do depends on whether the woman wants to become pregnant. If not, hormonal treatment and tranexamic acid is first choice, depending on the preferences of the women in question and maybe age. If this result is not satisfactory, then we could intensify coagulation correction. And if there's still persistent heavy menstrual bleeding, then it depends whether the woman wants to preserve her fertility, yes or no. And we discuss with the gynecologist what the next step could be. What to do in situation of acute heavy menstrual bleeding. This means that a woman presents with acute heavy menstrual blood loss, acute vaginal blood loss with a drop in hemoglobin level and hemodynamic consequences. Here we also again have to work together with gynecologists at this, maybe in the acute stage. The gynecologist needs to do maybe imaging, hormonal treatment, and maybe there's some gynecological intervention needed, or admission. And we should be there as a hematologist to correct the coagulation, immediately start tranexamic acid in a high dose IV, and continue orally. And if it's a large bleed, we should treat this as a large bleed. If they have in their treatment plan that they need clotting factors, then we should also administer clotting factors and maybe platelets if they have a very low platelet count. So we make a joint plan. Then also the anticipation on heavy menstrual bleeding in girls with a bleeding disorder. They should be educated on normal menstrual cycles when they are up to starting a menstrual cycle, so approximately when they are 10 years old, with a premenarchal consultation. The pediatric hematologist can do this, and also check hemoglobin ferritin levels to know what's the start, and to prepare them that they have tools, pads ready when they will start their menstruation, and also and make sure that they know what to do so they feel safe. If their menstruation starts and they do have heavy menstrual bleeding symptoms, which they are aware of because of the premenarchal consultation, then they should consult us again, and they can use the PVAC to assess how much blood loss they have. We assess hemoglobin and ferritin levels and start on tranexamic acid. If it's still persistent and it's confirmed with PVAC, then we can refer to a pediatric gynecologist and discuss hormonal options or intensify coagulation and see what happens. We have to closely monitor these girls, especially those with a high risk, such as morbus Glanzmann and type 3 von Willebrand disease. So to summarize, women and girls with bleeding disorders encounter unique challenges, and they are currently not met by all hemophilia treatment centers, comprehensive care centers. First, timely diagnosis. We need multidisciplinary diagnostic pathways, both to diagnose bleeding disorders timely in women with heavy menstrual bleeding and to recognize heavy menstrual bleeding timely in women and girls with bleeding disorders. Education is of paramount importance, and don't forget to take blood tests and measure objectively blood loss. Then when there is heavy menstrual bleeding going on in women and girls with bleeding disorders, we need to close collaboration with gynecologists, ideally in form of joint clinics. Anticipate for girls with bleeding disorders. Education is important of the girls and their family, and multidisciplinary treatment pathways both for chronic and acute heavy menstrual blood loss in our hemophilia treatment centers. So more research is needed toward optimal treatment of heavy menstrual bleeding in women and girls with bleeding disorders, both at the site of diagnostics as well as in the site of treatment. And we'll discuss more about this in section 3. If you like to educate your healthcare professionals that are not so familiar with bleeding disorders in your network, then it's possible to refer them to this website of Core2Ed. There are short micro e-learnings, also accredited, and they give short information on women and girls with bleeding disorders that is very comprehensive and, well, it's a tool to enhance education. Well, we end this first part of the e-learning with a quiz. Get ready. Which of the following statements is true? A. Approximately 50% of women and girls with bleeding disorders report heavy menstruations. B. Heavy menstrual bleeding management strategies are in place at more than half of the hemophilia treatment centers. C. Most HTCs have joint hematology and gynecology clinics organized. And D. 1 in 10 women with heavy menstrual bleeding at the gynecologist has an underlying bleeding disorder. Well, the correct answer is B. Heavy menstrual bleeding management strategies are in place at more than half of the HTCs. That's good news, but it should be better. Actually, approximately 50% of women and girls report heavy menstruations with bleeding disorders. This is a lot more, over 80%. Not most HTCs have joint clinics, it's a minority, less than half, and more than 1 in 10 women with heavy menstrual bleeding at the gynecologist has an underlying bleeding disorder, probably more in the rate of 1 in 3 to 1 to 4, 1 in 4.